Sig Bervin. He's going to be talking about problems with stopping at S1 and long thoracolumbar constructs, lumbosacral nonunions, and sacral fractures. So get ready to be wowed.
Thank you, Lucas. Yeah, it is an important topic. This section on complex lumbosacral pathology, I think, is really the foundation, literally, of complex deformity. These are my disclosures. I don't think they'll be relevant here. But when we think about challenges in adult spinal deformity surgery, in general, we talked yesterday quite a lot about alignment, choosing levels, UIV, LIV. Complications are certainly really important, especially junctional, which we're going to talk about now. And then the question, when can we do less? When should we do more? And that's fundamental to our value-based care. And I think sometimes doing less really is going to be a better solution. So again, just think about any case, the first, if we're going to be operative, how high, how low, and what type of technique, when to go front and back. And there's no area of medicine, I think, that's characterized by more variation than the approaches to spinal deformity. And to some extent, having this interdisciplinary group together, I think, gives us a great opportunity as a community of physicians who take care of disorders to learn from each other. So the overview of what I'm going to spend these 15 minutes on is, first of all, my strong preference is to fuse to the mobile lumbar spine. So my strong preference, when possible, is to avoid fusing to the sacrum. Having said that, in adult symptomatic deformity, most commonly there's symptomatic deformity involved in the lumbosacral junction. So it's unusual that we're able to stop in a mobile lumbar spine. Certainly in the adolescent and the growing spine, that's characteristic. Patient with primarily thoracic deformity, that's characteristic. But my strong preference, even in the adults, is to leave mobile segments. The challenge of the lumbosacral junction is basically can be summarized by the quality of the bone and the fact that there's high strains on the S1 screw. And if we think about any metric of biomechanics, think about what we're trying to do with augmentary techniques is to actually reduce strain on the S1 screws and get a solid fusion at L5-S1. We'll talk a bit about the role of anterior column support, and Chuck Eichler can talk about some challenges there, and I think Manish is going to address the anterior column as well. And with regard to pelvic fixation, how many points of fixation and when do we use it? And I'll tell you about scenarios both in degenerative as well as deformity where I use pelvic fixation pretty routinely. So again, in terms of broad categories of deformity, the junctions are hazardous. Cervical thoracic, we heard about a little bit yesterday. Thoracolumbar, we heard about a lot in terms of PJK things. And again, we're focused now on the lumbosacral hazards. And when we think about the modes of failure, in general, there could be symptomatic degeneration below a fusion that stops above the sacrum, nonunions or screw loosening at L5-S1, loss of correction, and then finally implant failure, which is a mode of failure that we see most commonly going to the pelvis. So I want to start with the case of when can we avoid going to the pelvis? What's the case for stopping short of the pelvis? There's some evidence, weak though, that we might have better function, less complications, good survival of the L5-S1 segment. I'll show you some work that Ganesh Swami did when he was a fellow. And leaving the option open for new technologies, maybe even motion-preserving technologies at L5-S1 if we stop short of the sacrum. With regard to function, this is a paper that came out of the Spanish group. Ferran Pellicer was part of this. But looking at patients fused at a thoracolumbar junction with an LIV, thoracolumbar L3 versus lower sacrum, or L4 to S1. And in general, the longer the fusion, the less mobility, worse SRS scores, more spinal pain. So there is some evidence to suggest that fusing short of the sacrum may make a difference. This is a paper, again, that Ganesh Swami is now Fred's partner out in Calgary. We wrote about some of the advantages of stopping L5. We maintained lumbar sacral motion, decreased the operative morbidity, and decreased complication rates, including revision surgery, broad failure, and infection. There was no clear functional advantage that we were able to demonstrate, but having said that, the survival of the 5-1 disc in this series was about 70% at 10 years, and this is the Kaplan-Meier curve that we came up with. This is a classic paper that was matched cohort analysis. Actually, when I was a fellow, this paper came out. Charles Edwards and the group at St. Louis, Larry Lenke, comparing fusion L5 versus S1. And this is where I've talked for a long time about the L5-S1 paradox, right? Is that when we're fusing L5, the fate of the L5-S1 disc isn't necessarily good. And they showed about 61% of these cases developed advanced degeneration. And when people developed advanced degeneration, they lost their sagittal alignment and they had worse scores. About 18% actually lost fixation L5. But the paradox is that stopping at S1 had more rod failures, more infections, and a higher revision surgery rate and more complications. So again, there's not a clear right versus wrong. This is a nice multi-center retrospective study that came out of the ISSG, some of the ISSG sites. First of all, propensity matching, because it tends to be a very different population who you stop at 5 versus 1. It tends to be older people, more severe deformity when you go to 1. But propensity matching, stopping at L5 at less PJK, less OR time, but they didn't show a big difference in other outcomes, including revision surgery. This is a nice meta-analysis that included 11 studies, over 1,200 patients. Stopping L5, less non-union, less PJK. Again, number one risk factor for PJK, fusion into sacrum, lower implant complications. There were some advantages to going S1, that if you really need to restore lumbar sacral lordosis and overall alignment, there's less loss of correction and better restoration of alignment when you go to S1. And interestingly, again, no difference in function or pain was shown in this meta-analysis. A lot of times when we're thinking about stopping short of the sacrum, we got to really identify where pain's coming from. The MRI and CT scan can be useful for here. Sometimes dynamic imaging to look for any instability, and sometimes even some provocative evaluation with facet blocks or even discography, which we don't tend to use now, but evaluation of where pain's coming from. Here's a case that was fused at another hospital. You see the patients in significant malalignments. They had a double major deformity. Typically, the thoracolumbar curve is more flexible than the thoracic curve, and you see how they're fused in a coronal and sagittal malalignment, junctional kyphosis above T6, and clear malalignment. And this is one, she was, I believe she was, 48 years old or so at the time of the surgery, and she was very interested in surfing and water skiing, and after the surgery, she had lost the ability to do all of that. So one of the things I want to do, we actually talked about sexual function as well, which may be compromised with long fusions to the pelvis. And what we ended up doing for her, and I'll just show you pre-op versus post-op, is I actually did a asymmetric PSO at L3, but the bottom line is I kept the fusion to L5, so I avoided going to sacrum. It's so often, or so rare, that we can avoid stopping at 5-1, but I realigned her without going down to the pelvis. And that can be a little tricky, but the bottom line is she got back to snowboarding, surfing, and water skiing was actually her big thing. Here's another patient, a 56-year-old male. He got injured in college. He went to school in Maine and flipped backwards over a balcony drinking beers and had a conus injury when he was in college. But very functional, hiking, camping, gardening, and he does a lot of four-wheeling. So he's got this pickup truck that comes up to my chest to get into. And so mobility at the lumbar sacral junction is important for him. Presents with progressive neurogenic claudication. You can see he's got junctional stenosis, both at L3, 4, and at 4, 5. There's the MRI scan showing the stenosis. So again, this is somebody who I tried to stop short of the sacrum. Went down to L5, so I did direct laterals or anisosas approaches at 3, 4, 4, 5, stopped him at L5. Did well for a while, got back to four-wheeling, got back to being quite active, but unfortunately, within about a year of that, progressive degeneration of 5-1, some loss of sagittal alignment, lumbar sacral pain, and I ended up taking him down to the pelvis with the front and back. Now part of the solution, that helps his lumbar sacral pain. You can see the type of four-rod construct I typically use in that construct down. So failures of fixation of L5, we all recognize, and there's any number of examples, so when do we have to fuse down to the sacrum? Well, number one is we recognize symptomatic degeneration of 5-1. Spondylolisthesis, I think, is an indication to include the sacrum. Symptomatic stenosis. When we need to get a major sagittal plane realignment, stopping at L5 can be difficult. Patient with bone quality of insufficiency, stopping at L5 is challenging. Certainly when there's fixed obliquity, I think going to the pelvis is a lot easier to correct the coronal plane. And neuromuscular disorders. These are all where I really tend to go to the sacrum. But it can be a very slippery slope, because once we go to the sacrum, that's where we're really opening up the door to even more complications. Why? Well, it's got a lot to do with the poor bone quality of the sacrum. It's got a lot to do with the loss of compensation that we might get at the lumbar sacral junction. Some of the things that I think are well proven, trying to get tricortical fixation of your S1 screw. So I tend to do these I do most of my screws freehand, but I'll actually use fluoroscopy to really get the screw right up into the intersection between the end plate and the anterior cortex, and I'll use screws that go right through that anterior cortex. And the insertional torque, you can really tell when you go through that anterior cortex. This is an important study to have in mind is Brian Cunningham took a look at what is a long fusion to the sacrum. And that the strains in the S1 screw, when you're at L3 or higher, that significantly increases the strain on the S1 screws. And specifically what he showed is using an ALIF, well, that'll reduce the strain on S1 by about 30 or 40%. But we think that a strain on S1 is why we get screw loosening and why we get loss of fixation non-unions. Reducing strain is why we use pelvic fixation. And the power of pelvic fixation actually reduces strain by up to 300%. So that's dramatically better than circumferential alone. And again, this is what we want to avoid, just kind of haloing around our S1 screws without pelvic fixation. And that's something we see too commonly in patients who don't have pelvic fixation. I think the other classic study besides Cunningham and McAfee's study is this study by McCord, where he actually used bovine specimens, and it was more of a biomechanical study. But the take-home message of this is to recognize that we want to get our fixation as anterior and as lateral as we can. That's what reduces strain on the S1 screws. And in terms of how do we get that fixation, how many people have put in a Galveston screw, Galveston fixation, right? So bending that's using a unit rod or trying to bend in Galveston screws, that can be really challenging. So the evolution, iliac bolts, and then sacroiliac fixation, that evolution has been significant. We actually looked at Galveston versus iliac screws and showed that the failure rate was a lot better with iliac screws than with Galveston. But still 20% of these patients required a revision because their iliac screws were prominent. This is a technique we used to use, go to the PSIS, ronger down, and try and get as medial as you can. But oftentimes these screws, especially the older screws from that study, were symptomatic. So I think a lot of us now are using the sacroiliac iliac technique. This was really described by Sponseller and Kabash and a group at Hopkins. And looking at this in a meta-analysis, some significant advantages of sacroiliac iliac screws over traditional iliac screws, both in terms of infection rates, where 25% of the iliac screw group had infections compared to only 2.5% of the S2AI screws. Need for revision surgery due to screw prominence and overall revision rates were all better with the S2AI screws. That meta-analysis, I think, was pretty compelling. And this is sort of the evolution of techniques that I've used over the course of my career, from Galveston to offset iliac screws to S2AI screws. And now you'll see a lot of these constructs are going to involve multiple points of pelvic fixation. So let me get to the issue of when to use pelvic fixation in spine fusions to the sacrum. And an overall summary, if you want to take a picture of this slide, this might be the most useful. Long fusions, the long fusions above L3 down to the sacrum. In shorter fusions, I often use pelvic fixation, including patients with osteoporosis, established pseudoarthrosis, high pelvic incidence, a high-grade spondy. And the interesting thing that we're recognizing, I think, more now is maybe people who have recognized SI joint pain before surgery. So a couple examples. 84-year-old who years ago had a fusion T12 to S1, no pelvic fixation, progression, loss of alignment, progressive pain, progressive weakness, actually. You see the sagittal malalignment, the haloing around the S1 screws, no inner body at L5 S1, no pelvic fixation. So this is one that I revised front and back, and even though she was 87 with a lot of comorbidities, got her realigned. What about in shorter fusions? I think this is a great paper that came out of the group at Cedars, looking at essentially sacral slope, but that's sort of a proxy for pelvic incidence. But recognizing that a patient with a high sacral slope, high pelvic incidence, a lot more strain on S1. And those are instances where, for example, a dysplastic spondy, 17-year-old with a dysplastic spondy, high pelvic incidence, routinely I'm going to be using pelvic fixation on these, not stopping in S1. Here's a patient with metastatic breast cancer. I'd actually done a T2 corpectomy on her a few years before. She developed symptomatic degenerative changes at 4-to-1. Osteopenic, not osteoporotic, did a 3-to-1 fusion front and back. So there's a 3-to-1 circumferentially. And she came back for her 4-week visit. And at the time, the fellow with me, I remember this very distinctly, he said, well, she's doing okay. She's got some pain in the lumbosacral area. And I was thinking, that seems really unusual. That's most of the time these patients got a dramatic improvement in their pain. These were her x-rays. And if you actually look closely, and you see it on a CT scan, she's got an insufficiency fracture. So even though it's a relatively short construct and circumferentially fused, she's got an insufficiency fracture below the S1 screw. So I revised that. This was a while ago with 2 points of pelvic fixation. What's the evidence that pelvic fixation fails often? Well, comparing iliac screws and sacroiliac screws, this is an ISSG paper that showed 23% of the time sacroiliac screws are either breaking or loosening or painful. And so we could do better than that. Here's an example of a case of mine, and I didn't talk today because I don't have enough time, but 1 screw versus 2 screw is historically, if people were well aligned, I'd use 1 screw at the lumbar sacral junction. We did some biomechanics on this. This is a patient who 2 years after my surgery ended up with a non-union thoracolumbar junction. But what was interesting was all of her pain was at the lumbar sacral area. So when I revised her, and that's the SPECT scan, when I revised her, I actually revised her down to the pelvis and augmented this with the triangular osteosynthesis devices to actually fuse across the SI joint. And that is the definition, that is the background of the Sylvia study. So is there an advantage? And this is important to understand. Smooth screws with or without a triangular osteosynthesis device. The important conclusions here to summarize is that the primary outcome was the new onset of SI joint pain. There was significantly less SI joint pain. That's something I probably under-recognized, but there was less SI joint pain. Importantly, there wasn't a big difference in patient-reported outcomes or in revision surgery. And that brings up the next question of, well, what about using a screw that's going to fuse the SI joint? And that's the next round of this clinical trial. And we don't have any data from that yet. But what about fusing the sacroiliac joint? Does that help us more than the Sylvia type technique? I'm going to wrap up just with, I think, one more case. Here's a patient, 67 years old. Turned out that she had hypophosphatasia, and I think Roger's gone, but DEXA score is minus 3.4, presents with sagittal and coronal malalignment. This was her pain diagram. Preoperative optimization was quite interesting for hypophosphatasia, but I won't go into that much. But this was her realignment, and this is more typically what I'm doing now, is 4-rod constructs with 2 points of pelvic fixation on each side. So S2AI screw and an iliac screw to get that realigned and robust on both sides. Last case is a Charcot spine, maybe one of the most challenging pelvic fixation cases. 40-year-old, had a thoracolumbar injury, prior fusion down to, I think, L2, and down L2, 2-3, complete dissociation, Charcot spine, very challenging biomechanically. And this is one, again, I repaired with a 4-rod construct. So 2 S2AI screws, 2 iliac screws, 4 rods. So in conclusion, I think that fixation in the lumbar sacral junction is challenging. And I think it's really important to get this right because this is where we see a lot of failures in reconstructive surgery. Think about strategies to reduce strain on the S1 screws. Anterior column support is one of them, and good pelvic fixation anterior to the osteoligamentous complex is important. Supplementary SI joint fusion really remains to be proven. I think the Sylvia study suggested that there's less SI joint pain, but more work needs to be done for the role of more robust screws and actually fusing that with 4 points of fixation. So thanks for allowing me to set that off, and I don't know if we have time for questions. We'll take questions at the end. Sure. Any questions? Yeah, Rich.
So in 2025, almost going into 2026, is there any role for stopping at S1 long segment fusions that are L2 and above?
Yeah, I really don't see an advantage to stopping in S1. I think L2 and above, L3 and above, there's too much strain on that screw. And even with the circumferential fusion, even in a younger person, in a young female for a high-grade spondy, for example, I think about maybe putting in iliac screws instead of S2AI screws to not actually fuse the SI joint and maybe even take them out down the road. Those are the sort of things I think about. But I don't see an advantage in the adult with deformity to not going to the pelvis, even with the circumferential fusion, even with the patient who's well aligned. Yeah. I think we got some more talks on the topic or questions.
Your preference on S2AI and iliac, are you using combined on both?
When I use 4 rods, I'll use S2AI and iliac. I tend to really bury that iliac screw, so it's a really medial start point, so they're kind of almost parallel. But when I use 4 rods, I'll tend to have 2 points on each side. If I'm just using 2 rods, which I'll often do, and I look forward to our SMART study, but with 2 rods, I just use S2AI screws because of the advantage that meta-analysis showed.
Perspective, you have seen instrumentation stop at S1 and the failures distally. Pelvic fixation prevents that, but it may transmit the stresses proximally.
Yeah.
What do you think's worse for the patient from a revision standpoint? Do you think a distal failure is worse or a PJK?
Yeah, really, really important question. You know what? One of the things that Keith Bridwell used to say, and you and me certainly know this, is he said, "I'd rather have a rod break than a screw loosen," which is sort of an interesting paradox, an interesting trade-off. So if we had to choose between a failure of pelvic fixation versus a junctional problem, in general, why I'd say, let me stop at L5 is if I've only got a revision rate of 30% at 10 years, I'll stop at L5 because going down to the pelvis isn't that big of a deal. Having said that, I think, junctional problems tend to predispose to more junctional problems. So if I had the choice, the one thing I'd want to avoid, and I think Raj was alluding to this and stopping it without iliac screws, is I want to avoid that sacral insufficiency fracture with a deformity. That's, and you're going to see one of my cases soon one that I revised with an S1 osteotomy, but you'll see one of those soon, and that's a tough problem. That can be a really tough problem.
It's an interesting question too, because by avoiding one, it may not necessarily be a logical one or the other, because once you fix to the pelvis, I wonder if then they'll just have the PJK risk moving forward right afterwards. So they could just end up having both in that way too.
I find once they're stable and the fusion's stable, even
At the
down
top?
on the bottom, I find I don't get the same PJK.
Really? Okay.
And the primary I would, but as a revision, I often don't.
That's interesting.
Yeah, and the other thing about that is not actually dissecting all the way to that thoracolumbar junction, so leaving that soft tissue envelope as intact as you can, so just doing the work down below L3.
Yeah.
Yeah.
That's great.
Well, thanks for letting me lead that off.